Hello, good evening and good morning to everyone who's joining us today. Welcome to our next webinar under the webinar series on the front lines, curated by the Harvard T.H. Chan School of Public Health, India Research Center and Project SANCHAR. To give you a brief background about the India Research Center, it is the first global center of the Harvard T.H. Chan School of Public Health. Established in 2015, the center has three strategic goals of research, teaching, and translation of evidence into policies and programs. The center provides a platform to facilitate faculty exchange and partnership between public health researchers and Harvard Chan faculty. The center is led by Professor K. Vishwanath, who is the Lee-Kum-Kee Professor of Health Communications at the Harvard T.H. Chan School of Public Health. Project SANCHAR is aimed at building the capacity of journalists to draw on the latest science and data for shaping public knowledge, attitudes, and policy on health. Today, we are also glad to partner with Google Research India to bring forth an interactive webinar on the use of artificial intelligence for public health and social good. Google Research India works on fundamental advances with respect to robustness, explainability, and fairness of machine learning methods and application of artificial intelligence to tackle big problems. Google Research is working on new approaches to healthcare, agriculture, and education, and on improving apps and services such as search, assistant, and payments to deal with challenges arising out of the diversity of languages in India. Google Research's work is spread across various sectors, including health and biomedical science. Through the application of machine learning, large-scale computing, and human-computer interaction, they hope to deliver and help people live healthier, longer, and more productive lives. And joining us for this webinar today are 5 distinguished academicians and practitioners of AI for social good. To begin with, we have Professor Milind Tambe, who's the Gordon McKay Professor of Computer Science and Director of Center for Research in Computation and Society at Harvard University. He's also Director, AI for Social Good at Google Research India. We're also joined by Dr. Rahul Panicker, Chief Innovation Officer, Wadhwani Institute for Artificial Intelligence. Dr. Aparna Hegde, Founder, ARMMAN. Dr. Zevenbergen, Research Scientist, Google. And we'll also be joined by Ms. Anna Roy, Advisor NITI Aayog, who led the development of the National Strategy for Artificial Intelligence. Ms. Roy will join us at 7 p.m. But let me start off with Dr. Milind. You already have such an accomplished CV, but just to add to that, Professor Tambe also heads the Google Research India, which we have already said, and his research focuses on advancing AI and multi-agent systems research for social good. He received his PhD from the School of Computer Science at Carnegie Mellon University. So let me get on with the session today. What, in your opinion, is the potential of deploying AI for social good and for public health in India? And while applying these principles, what are the unique barriers, Dr. Milind, that you found for AI-powered solutions in low and middle-income countries?
So for me, AI for social good implies that really it has to deliver social good. It cannot be just that we are motivated by some doing good in the world. Actually, we have to see social impact in real life. Now, AI is something that we see all around us in terms of, when you type something into Google, it completes the search strings or Netflix recommendations, or in the future, maybe driverless cars and so forth. But when we talk about AI for social good, we are talking about delivering benefits of AI to more vulnerable communities, endangered communities for more sustainable solutions. And generally to those who have not benefited from AI in the past. And we see a tremendous opportunity, very optimistic about the use of AI for social good, for public health in India. At Google Research in Bangalore, we held a workshop in November of 2019. And we found that, a lot of nonprofits were able to come and show us how they are really doing very inspiring work in the field. And they're sitting on a lot of data. And so there's a lot of opportunity there to actually apply AI. A concrete example is, of course, work that we are doing with Dr. Hegde's NGO called ARMMAN, and she will talk more about it. But just to give you a preview of some of the work that we are doing there. Their work is in the area of maternal and child care. In their Mitra program, they deliver information to expecting moms and after the baby, when the babies are very young. And they do that by calling these moms in an automated fashion and delivering that information. But sometimes moms drop out of the program. So if we can predict in advance based on the pattern of phone calls, which were picked up and not, who's going to drop out ahead of time, then we may be able to intervene on these moms before they drop out and allow them to stay in the program. A similar situation arises, for example, in TB, tuberculosis program, medicine adherence. Patients are supposed to call every time they take a pill, and health workers can know who's taking a pill and who's adhering to TB medicine or not. But if we can predict in advance based on the phone call pattern that somebody's going to drop off, then again, we can intervene on them. There's actually 6 separate projects that we've started out of Google Research India in the areas of public health and conservation. And these go into areas such as HIV prevention. And in terms of conservation, just to give you an example, also look at things like human-wildlife conflict and trying to predict that in advance so we can intervene. So there's a lot of opportunity, a lot of different possibilities of applying AI for social good and public health. And I can go on, but I also wanted to talk a little bit about some of the difficulties that you mentioned that we have to be aware of. We are supposed to be living in a world with lots and lots of data everywhere. But when we talk about AI for social good, because we are working with these vulnerable communities and so forth, we often really don't have that kind of data in hand, or the data is not very clean and so forth. And so sometimes students who are working with these problems will get very frustrated because they say, there's not this very clean data they expected. But that is the research challenge, how do you deal with that kind of lack of data? A second is that we have a lot of tremendous AI talent in India. I mean, a lot of wonderful PhDs being done in AI. But on the other hand, often they're working on perhaps more abstract problems, or and there's the NGOs who really need the help. And somehow we have to work on somehow facilitating this matchmaking. And if we can, then I think there'll be tremendous explosion of AI for social good work. And I hope that we can contribute to that in the future. A third point is taking solutions from abroad and just applying them directly into the Indian context may not work. So for example, there's work on fairness, but fairness often gets translated into different racial groups, which may not be applicable when we talk about explanation of AI solutions and so forth. In a country where perhaps people have low English literacy, this needs to be done in a different way. So there are some barriers that we need to overcome, but these are also wonderful opportunities where we as AI practitioners, researchers, I believe can contribute. And I'm really looking forward to allowing us to really, start this AI for social good revolution, if I may say so, in a big way, so that benefits of AI can reach all of those who have not benefited.
Right. Dr. Milind, thank you so much for setting the context. I think it's a great platform you have laid down, and this is going to guide us, our panel today. I'll come to you, Ben. Could you take us on what are the major concerns, solutions, and problems that Google is looking to address through AI?
Yeah, well, thanks for having me here. Yeah, I think there are plenty. I think Google recognizes that if you exploit AI systems, if you have them, you have some responsibility as well with the power that you enact. You have to show the best practices that you find and take responsibility for some bad outcomes and be able to mitigate for those. So I think what Google's done about 2 years ago is come up with the AI principles. It's a set of 7 principles that they want AI to do or to pursue. Things around fairness, safeguarding privacy, making sure that systems are safe and secure, making sure that systems are accountable and that they can explain their actions to users where appropriate, of course. So it's those kinds of issues that we're trying to figure out how to optimize for and how to really implement these into the internal systems, but then also communicate outside what we are learning and what others could learn from that, and how they could implement those types of practices in their own systems, in their own governance. I think along with those AI principles, there are some areas that Google doesn't pursue. You can find them on the website. I won't go into them in detail, but that's also important to be explicit on what it is that you're not going to start contributing to with the systems that you have. And in addition to that, there are some general sort of responsible practices around just the use of technology, but especially in AI, where you have to test your systems a lot on an ongoing basis, even after you've launched, just to make sure that they are running the way as you had intended, and the way whether they adhere to the principles that you set out to defend. So yeah, fairness was mentioned. There are efforts ongoing in figuring out what that would then mean in the Indian context and across the whole world. Privacy is probably a bit more uniform, especially if you take technical approaches to privacy. But then again, the governance is contextual once again. So yeah, there are many ways, many things that we're pursuing and that we're vigilant for.
Right, and you spoke about fairness, and I just want to stick with that right now. This is quite a challenging aspect for most engineers, and also the ethical aspects of how do you sort of implement AI. How does Google go about the fairness project, if I may call it? How do you ensure that?
Well, I should mention at the beginning, I joined Google from academia on March 2nd, which was a week before everyone went home. So I had 1 week in the office, and then I did the rest from home. So I have to admit that I'm not the most educated on how we're doing these things internally yet, although I'm getting there, learning as we're doing now, via video conference. But yeah, so I have a lot of colleagues working on this day in, day out, and they're doing a lot of technical research in figuring out how do you find that data sets are potentially biased in some ways, but also social research and figuring out what does fairness actually mean in the context that systems are being deployed, and what does that mean for the technical research that's being done, or the choice of fairness metrics that you use on the system. It's important that fairness doesn't equate necessarily to ethics. It's one of the concepts that is important to take into account when building systems. It's a very important one, especially when using such vast data sets. But yeah, it's a combination of social understanding of how do we even perceive fairness in these contexts, and which technical tools do we have to mitigate certain biases, ensure fairness, and sometimes also being able to admit that it's probably not a technical problem, but the system, any system, will probably just not get the right outcomes in that particular context. So we have review procedures for that with a lot of people who take that very seriously.
Right. Well, thank you so much, Ben. I think this is something that will keep coming at, and we'll come back to you again. I want to come to you, Rahul, from the whole philosophical debate about AI to the practical part of it. Your organization is working on a very interesting initiative. This is the Cough Against COVID initiative, where you're collecting the sounds of people coughing in an effort to use AI to determine if a person is at risk of COVID-19. And the project has received a go-ahead from the Indian Council of Medical Research. This sounds really fascinating. Could you take us through this initiative?
Sure, yeah. I mean, when COVID started, we looked what are ways in which we may be able to help those on the front lines. And there's multiple things we're doing. We're helping various cities with resource planning and projections so that they can, rather than be reactive, they can be proactive in building capacity. Another project that we have going is Cough Against COVID. Simply put, it's this. We know that the world will not have enough testing capacity, lab-based testing capacity, to test everyone who has a fever and a cough, or potentially came in contact with someone who has COVID, or without even them knowing. Even if some places have capacity, that capacity will not be geographically fairly distributed. Rural areas will suffer. We know, we are already seeing this in India. Large parts of the developing world, this will continue to be true. So the simple question we asked is, meanwhile, there was anecdotal evidence surfacing that okay, the COVID cough is not a typical cough. There's something different about it. May not be very, very specific to COVID, but it's certainly not a run-of-the-mill cough. So can we pick something up from there? It was purely that level of hypothesis on which we started, but we said, it's high risk, but it's worth trying. Where we stand now, in fact, we haven't gone public with our results. We're going to announce that shortly, but I'm happy to share here. What we are seeing is that we can potentially, two things. We are seeing statistically significant results on being able to detect COVID signature in a solicited cough. So even if the patient does not have cough as a symptom, if they were to cough into their phone, we are able to detect that. Of course, there's a particular sensitivity and specificity, and I'll come to that. Second thing, and this is something new to medical science, right? And if you listen to this cough, it's not something that you can pick up, but algorithms are able to do it. And secondly, we're able to see this even among asymptomatics, right? Which is very interesting because the vast majority of COVID patients out there are asymptomatic. And with this, if we do the numbers, we're seeing that at current level of performance, and our performance will improve, with no additional trained personnel or reagents or facilities, we should be able to increase testing capacity by about 60%, because we can effectively target the limited tests, lab-based tests you have, to those at highest risk. What our algorithm gives is the risk score for anyone who sort of uses this application. And we can target the limited lab-based tests to those who have highest risk. That's where we are, and we are in the process of passive evaluation and actually getting it out there.
Right. So we'll see if AI can sort of replace the experience of pathologists. I mean, that's
no. We won't even attempt that.
Okay.
That wouldn't even be the attempt, right? This would be simply the pathologists are stretched thin, right? The labs are stretched thin. So how do you make sure that it's the highest risk people who get their time, right? So that we give our pathologists, we focus their energies.
Right. And can you quickly respond? How far are you from the validation stage? Before I head to Dr. Aparna.
Oh, sorry.
How far are you from the validation stage?
I mean, we have our results on our test sets. Now we are entering validation.
Okay, great. So
backed by the Milind Association, various state governments, and
great.
the North Partnership Initiative.
Right. So best of luck. And I think we will be coming back to you again. So let me head to Dr. Aparna Hegde. I mean, we introduced her just as a founder of ARMMAN, but let me also add she's an associate professor of urogynecology and head of the upcoming department of urogynecology at Kama Hospital, Mumbai. So Dr. Aparna, thank you so much for joining us. Could you tell us about the priority areas for ARMMAN and how it has, you and Dr. Milind have worked together, as Dr. Milind just pointed out. How have you been using AI to address some of the issues in maternal mortality?
Yeah, so ARMMAN came from my experiences during residency in Mumbai, before I went abroad for further training. And I clearly saw how systemic problems, which are pervasive, led to loss of lives and mothers and children that were completely preventable. And so early on, we realized that technology is extremely important to create cost-effective, scalable solutions. So ARMMAN leverages technology, that is mobile technology, to create such solutions, both on the side of giving information to women, because I had been in antenatal clinics which were so overcrowded that we did not have time to even look at the patient's face. Forget giving them counseling information. So women would come back dying or children would come back malnourished. And so we started this program called mMitra, which is a free voice call service that sends time-in targeted preventive care information directly to the phones of the enrolled women through their pregnancy and infancy. And so mMitra really scaled across the country, and because it reached 2.2 million women, and so we partnered with the government of India to take over their program called Kilkari, which is similar to mMitra, which works in 13 states of India, and the reach is almost 18 million women now. right? And on the other hand, we also manage the Government of India's ASHA training program, which is also a mobile health-based refresher training program, which trains ASHA workers. There are 4 hours of content. Is again M-Health based. Now we are dealing with a lot of data, right? And we realized very early on that we need to really analyze the data properly to create targeted programs. And when I met Dr. Milind Tambe, I realized that AI would be a wonderful way of doing that. Right. And so what are we doing? So when we send MMitra information to women, currently we have 3 lakh women receiving MMitra and 3 million women receiving Kilkari ongoing currently. And so it is very important for us to understand which women are going to listen to the messages and which are not going to listen to the messages. Because if we can pick up those women who are not going to listen, we can create targeted programming. Right, we can ensure that we have the health workers go and visit them, or we can call them directly through our call center, because we have a fully staffed call center which engages with the women. So we worked with Dr. Tambe's team in Google Research, and they built an AI model which can predict at the time of enrollment who are the low listeners. Right, so if we can predict early on who are the low listeners based on the enrollment data, we can actually go and target them earlier. So we already are at the stage where the model has been built, it has been validated, and we are currently doing a study where we've got a control group, which is as usual. Then we have another group where we picked up the low listeners and send them SMSs, kind of see if they're going to come back and listen to us. And we have another group to whom we are sending voice calls, right? So we are actually calling them. A live person is calling them to understand why they're not listening and motivating them to, start listening to the voice calls. And I'm very happy to say that, the model is working, because they already validated that with our data. And now using that model, we have predicted these low listeners, and the women who are listening to the, receiving the SMSs, they are actually listening more often than the control group, right? And the women who are receiving the voice calls are doing even the best. Right, so after receiving a voice call, they started listening to our voice calls even more. So this is a live example of how we used AI to improve, access to information for the women that we serve, and that's going to lead to better maternal child health outcomes. Because if you're going to get preventive care information, you can take better care of yourself and your child, and ensure that you have better health outcomes.
Right, great. I think that's something which I was just going to ask you, that if let's say this takes off in a big way, what does this mean for public health in India? What does this mean for maternal health in India? Do you have a data, let's say a predictive data on how this could change the lives of women?
It's tremendous, right? So imagine, we're talking about almost 30% of women who might drop out, right? 30 to 40% of women who might drop out. And if we can actually catch them early and ensure that they stay with you and listen to the messages. And maybe there are some women who are not going to listen to you no matter what. And you pick them up early and ensure that the health workers go and visit them. Right. And look at the potential, right? We're managing Kilkari through the country, right? So Kilkari is in 13 states right now, and we are on track to reach through the country in the next 5 years. It's talking about literally, 30 million pregnancies per year, right? And you're talking about reaching at least half of them through Kilkari. And if we can kind of ensure that they listen to the messages through pregnancy and infancy, and these are more intensive than regular care. What happens traditionally is that you have traditional models where they come to a hospital which are overcrowded, or an ASHA worker visits them. She can't do that regularly. Her training is not good enough to kind of counsel her with all the information that a woman requires to pregnancy and infancy, and she doesn't get incentive for counseling. So these technologies where we're using voice calls to reach across to them really enable us to ensure that the women are informed about how to take care of themselves, ask questions early, pick up the risk factors, and go and seek care early. And if they seek care early, of course, they're going to be picked up and their complications are going to get managed early, and that's going to lead to reduced maternal child mortality and morbidity.
Well, all the best for that project. We'll come back again to you. I think it's amazing that a small intervention can have such big outcomes. I'll come to you, Dr. Milind, again. We are in the middle of a pandemic. We don't know when the things are going to end. And but COVID also sort of provides an opportunity for researchers across various streams to imagine and to come up with solutions which we had never thought before. What, according to you, we can do, or we can put AI to use in terms of managing a pandemic or future pandemics, for example?
So, so far you've seen the role of AI in COVID in many different ways. So I work in this area called agents and multi-agent systems, where one of the things we do is agent-based models. And the model that came out of Imperial College is an agent-based model that led to the global lockdown. So in a sense, we could imagine that AI has already played a big role with, obviously, with its pros and cons in terms of what kind of modeling results have been delivered. So that's clearly a real application of AI. And in our own work, we've been building these agent-based models in order to predict numbers of infections and rise in total numbers of deaths based on, in our case, it was in Georgia and Florida and so forth. So this was work that we did very early on when the lockdowns were going to be lifted in those states as to what the impact would be in order to potentially provide policy recommendations. But more recently, we've been looking at things like testing, again, using agent-based modeling and simulation. So for example, a place like Harvard, what kind of testing regime should we use if we want students to come in? Should we be testing students with a highly accurate test because that's very expensive? But the problem with a highly accurate, very sensitive test is that not only is it expensive, it takes a little bit of time to get the results back. On the other hand, a less sensitive test, which gets results quickly, could be cheaper, but of course it's not as sensitive. So what's the right test to be using for students or in other campuses? And what we've shown is that this test sensitivity is not as important. What's important is more frequency, even if it's less sensitive. Because if you just have a little bit of delay in getting the results back, it negates the use of having that more sensitive test. So that's the kind of work that we've been doing. But there are, of course, other opportunities that people have been exploring. Rahul talked about cough against COVID. There's also hotspot prediction, and there's also things of we are getting ready now, working in one of our collaborations for delivering vaccines or trying to figure out how vaccines will be routed, for example. So there are many opportunities for how AI may play a role now and in the future in terms of responses to the pandemic.
Well, great. I think we need these interesting studies that's coming up, especially on the sensitivity part, the test sensitivity. I think there is so much debate happening on how often should we test, what's a good test. But what you're saying right now is something that can guide public health professionals in a big way. I hope you publish the study soon and we get to know more about this.
Right.
So So Miss Anna Roy is here. She's joining us at before time. So thank you so much, ma'am, for joining us. Quick introduction of Dr. Roy. She was instrumental in bringing out the NITI Aayog paper on National Strategy on Artificial Intelligence. Ma'am, thank you so much for joining us. Let me quickly start off with you on how has artificial intelligence helped the Indian government's response to public health challenges? Could you kind of give us some practical examples? And also, since we are talking about COVID, is there something that the government has been working on using AI to address the epidemic in the country?
Thanks for having me, first of all. And sorry to be joining late. I was on another webinar, work from home, so all mixed up. I was with Anandan in my previous webinar, and now with Rahul. So, good evening, Dr. Tambe. Nice to meet you. So, Divya, I think it is a bit premature to say that AI is being used in public health as of now. I think we are in very early stages, and when we speak about modeling, etc., Milind spoke about it. Arogya Setu was a great initiative which was developed in record time through a public-private partnership. So that kind of took care of the data part of it. And then there were several, on the back end, I don't have those numbers readily, but identification of hotspots, contact tracing, alerting people, all that was done. I get a bit uncomfortable talking about AI in this kind of a context, because the line between data analytics and AI becomes kind of blurred. So I would be more conservative when I say this is AI and this is not. So something, I may not be correct, but for me, AI is something where you can actually kind of go ahead and predict something. Say, if you are able to use drones and the images which the drones capture to kind of predict something, put your AI tools over that. That is something which I would feel is a real use of AI. We kind of loosely use data analytics, like National Health Authority is presently doing an exercise of fraud detection in various various policy demands which they get. Now, will you call it a AI, or will you call it a data analytics model? So let that debate be there. I feel the potential of AI is far a bit in a future. We are not really there. I don't know whether Rahul spoke about this very interesting project which their center is working on weighing babies. And that is what I feel is the true potential of AI. And the day we are able to scale up, and when you talk about public health, then it has to be at scale. It cannot be a one hospital or a one health center. So when we are able to deploy these solutions at scale, that is when I would say that AI is being used in public health systems. So that is my personal view in the matter.
Right. Thank you so much, ma'am. I mean, it's a good context on how governments are thinking about AI. I think it's very important perspective to have. We have 15 minutes before we go on to the Q&A, and I can see the Q&A box just firing up. But I want to take one round of questions from our panelists. I'll come to you, Ben. We have a government representative here speaking about that it's too premature to talk about AI in terms of scaling up. Yes, I know that you've just joined Google and you're still working from home. However, from your academic experience, how do we bring together private organizations, governments, and civil society in one platform to sort of address important issues such as scaling up and data protection and so on and so forth? What's your view on that?
Yeah, so I think there's an important role for government to play in making sure that values are aligned, that system builders and those who implement them are working towards the same good goal, the AI for social good. But that is a tricky role to play. It's not just a matter of facilitation of several people around a table and people sharing their institutional priorities and interests and values. It's a tricky game where, at the moment in many countries, laws are not fully applicable or maybe even appropriate for the tools that we're building. Some are, others will likely need to be updated, and you see efforts all around the world. But at the moment, if you are implementing systems, there is an ethical discussion to be had, and the ethical discussion is far beyond just sharing points of view. It's it's an academic discipline that provides many different theories of how to take different competing values, competing interests, institutional priorities, and actually figure out what the most justifiable and defensible path is to take in the design of your systems, in the governance of your systems. And that will differ per context. The Indian healthcare context is going to be different from the Dutch healthcare system where I am, and again from the US one. And again, those principles and values and tensions and the way you reason about them and what is most defensible will differ in banks or in agriculture. So there is no set answer. But I do see that there's an interesting role for governments to play in facilitating this conversation in a constructive way.
Right. Thank you. Thank you so much, Ben. Rahul, coming back to you again. How has been the impact? What has been the impact about the interventions that you have done, especially the TB program? I understand that your organization is working with the National TB program, and also the initiative which Ms. Roy mentioned on weighing low birth babies. Could you quickly take us through the impact that this initiative has been?
Yeah. So in fact, I'm happy to share that, because as an institute, we are 2 years old, and we are very careful to do that. We want to do these things right, and therefore pretty much all these projects. I mean, TB is early on, but all the other projects are in an evaluation phase, and we could have sort of gone faster and put it out there, but we know that that's not the right thing to do when it comes to AI solutions, especially when it comes to underserved populations, and or when it comes to issues of healthcare. So all our projects, the furthest along, are in various phases of evaluation. Having said that, I think this is one. I mean, you broadly asked about the kind of challenges that AI faces, right? I mean, I could AI for social good or public health solutions face. I mean, there's many I could touch upon, and one is a burden of expectation, right? There is an expectation in. I mean, these have to be done through partnerships, right? Because deployment, data acquisition, crafting the right solutions, modifying workflows, all of those human factors, all of these have to be considered, and these have to be done through collaborations. And there is, we do have to take the ecosystem along. And the expectation out there frequently from the ecosystem is, oh yeah, you have the data. Let's, where's the model, and where do we, let's deploy. When are we scaling? That sort of thing. And then we have to say, hold on, right? Data we collected in for example, Vardha doesn't translate to Nanilam, and we can show you that, right? So things have to be evaluated things have to be contextualized, failure modes have to be analyzed, and so on. That's the safe. And so there's a lot of education that has to be done. And one of the big challenges that AI faces, both in public health and social good, is the burden of expectation. It can be a good challenge, but it's something that has to be managed.
Right. I want to come back to Anna Roy. Ma'am, as you rightly pointed out, that we are still in a nascent stage of sort of rolling out AI in our country. However, we need to have regulatory framework in place. What is NITI Aayog doing in terms of facilitating the use of AI among private enterprises, or how is the conversation that that NITI Aayog has had with private companies in terms of the use of AI in India?
So I think again, I don't know, I may be the naysayer, but I think it's too early to talk about regulation. We, as Rahul said, we are still evolving. Now, it's a good point which Rahul made. I think what we really need to talk today about is awareness. And we talk about AI as the panacea of all ills. We feel that it is the magic potion which we just have to open the bottle and put somewhere, and boom, everything is addressed. It's not that. I will not name the country, but there was this country who wanted to deploy AI tools developed in that country in India, and I was dealing with the top people, representatives of that country in India, and they just thought that here is this tool, why don't you just go in your hospitals and PHCs and deploy it? I had to explain to them at length, to tell them, look, this tool was developed on X population. It cannot be just deployed in population. You need to have the data collection, training data. You have to have gold standards. You have to compare it with gold standard before you can. And especially in health, you cannot play around with or for that matter, you can't play around with education or agriculture or anything. In agriculture, a leading tech company, problem is not just with researchers. Problem is also with these big tech companies who go to all these countries and say, we have this solution, we'll give you precision agriculture here, we can do this, and big kind of claims. Now, how do you deploy a tool which you developed on data collected in US in India? That is not possible. And this is what responsible big tech companies are doing actually. So and I don't want to regulate them, I want to create awareness. So as a policymaker, people like me should ask the right questions. So we are on awareness. So we are actually saying regulation is not, this is not the right time for regulation. We have recently released a discussion, it's a deck. The paper will come soon. We are going through consultations with various stakeholders on AI ethics, because anything like a Cambridge Analytica can throw the baby with the bathwater. Imagine already in your Q&A somebody is questioning me that your Arogya Setu has huge privacy concerns. So we need to be conscious about these things, take informed decisions, and when we take a decision, then we should have the courage of conviction to say, yes, we took this decision, these are the privacy issues, this is how we are dealing with it, this is how we are not dealing with it. So for me, the important thing today is to talk about awareness, and I would call upon all the experts around the table today to focus on that. Asking the right question is the important thing. Talking about regulation, talking about anything else, I think is meaningless.
Right. I think that was quite a frank point of view. And thank you so much. Ben, do you want to quickly respond to that, considering you are the Google representative in this panel? We have 4 minutes before we start the Q&A.
I can also respond.
Yes, please. Of course.
And then hand this over to Ben. I mean,
Sure.
I entirely agree about the limitations. And I mentioned earlier also this, you can't take solutions from abroad and just apply them directly in the Indian context. So in all of our work, whether, before I joined Google or since then, the work is always in collaboration with and in service of a nonprofit's ongoing work. So they are the people who really know the realities on the ground, whether it's, youth experiencing homelessness in Los Angeles, or wildlife conservation organizations, or, tuberculosis prevention, whatever it is. It's the government or non-governmental organizations who are directly dealing with the people. And what we end up doing, at least in our work, and in the work we are doing in Bangalore, is really working with the nonprofits, such as with Dr. Hegde's ARMMAN, in order to deliver a solution that would be valuable to them, rather than us by ourselves pretending that we know the ground realities and saying that here's a solution that's going to work. So that's been the strategy that at least we have adopted and found to be useful. But I'll hand this over to Ben for his answer as well.
Yeah, thank you. So Ms. Roy, you maybe weren't there. I only joined Google about half a year ago. And I've been ramping up via video conference. But what I've seen so far is that there are a lot of efforts starting up internally with people realizing some of the issues that you just mentioned, and starting very contextual socio-analyses of how the technology works in particular countries. It's hard, but it's definitely something that I'm working on as well. I've been working with great colleagues from India recently to start thinking about this. Now, obviously, I'm not an Indian, but I am an ethicist, so I can help with some of these processes. There's a long way to go for everyone, but yeah, the efforts are there and interesting.
Right. Thank you so much, Ben. I hope I didn't put you in a spot, but I think it was important that we get both sides of the discussion. We have 1 minute before we start off. We open up for the Q&A. So I want to come to you, Dr. Aparna. You work in the public health setup, and you work with limited resources, handling a large bulk of patients across the country, and of course across the cities who come to you. how much is the openness or the need for innovation in public health setups, like public hospitals? What's your experience on that?
Oh, and there's tremendous need for innovation. Given the fact that our population is so huge, our traditional methods are now going to be enough to cover the entire large population. That's why when I started ARMMAN, technology became the way to create scalable solutions. Because when you create resource-intensive programs, they don't scale across. Right. So if you want to design for scale from day one, technology becomes a really good conduit to do it. The only thing is that you have to use easy to use technology. I mean, you can't be creating the next jazzy technology might seem very good in a conference or in a small pilot, but when it scales across, it may not work, right? So you have to really work with what you have. That's why we use mHealth, because it's something that every woman has, right, or every family has access to, and every innovation that's going to come in mHealth is going to be adopted by the women themselves, right? So we just have to keep pace with the technology change that they are experiencing themselves. So what I realized is that obviously innovation is necessary. People adopt it, but you have to design for that properly from day one. You should know your parameters, right? Are you designing for scale? Are you designing an intensive program, right? And also one very important thing one must realize is that it can't be just technology, right? It has to be tech plus touch. You cannot have a public health program that's pure technology. The way ARMMAN works is that we have a tech plus touch approach where we have, our MMitra program I spoke to you about, or even Kilkari with the Government of India. We have the ASHA worker and the ANM in the field introducing the program to the women, right? MMitra, we have health workers introducing the program to the women in hospitals as well as in the slums. And we have a call center manned by women who, trained counselors who the beneficiaries can call to ask any question. So it's never tech alone, right? And coming to AI, right, what our experience has been, and it's been great with the Google team and Dr. Milind Tambe's team there, that, AI is an enabler. You need to know the right question to ask. It is not the panacea for everything, but if you ask the right question, so we asked the right question here, right? In our, we already published Dr. Tambe's team and us published a paper on it, right? Already within a short while, we have come to a point where we understood how to pick up the low listeners and understood how to create an innovation to kind of ensure that they get taken care of. Similarly, if you look at content, right, we need to understand what kind of content will be imbibed with which kind of woman, given her socioeconomic, status in society. And then if we can create different kind of contents for each, right? So if we can understand which woman is likely to be high risk, right, based on her, models we have created based on her parameters, it will be easier for us to understand, target those high risk women. So the questions you ask are more important, because if you ask the right question, you get the right solution.
Right. Great. I think that was a great explainer. We will open up for Q&A because it's, as I said, the Q&A box is just firing up, and I'm sure our panelists are also reading from the box. I'll take the first question. This is from Dr. Vish. The question is to Dr. Milind and Dr. Aparna. Some of the women in the case study that you mentioned may have structural barriers such as conditions at home, poverty, geography, etc. Is there a way to overlay data from smartphones with more contextual data? Have you tried doing that? Dr. Milind, do you want to answer that? And then we'll go to Dr. Aparna.
That's an excellent question from Dr. Vish. And exactly as Dr. Aparna said, the whole point here was to pick the right question to ask at the beginning, which was from an AI perspective, it's not the kind of the fanciest of research questions, but it's the right question to ask in order to make these predictions. Having done that, the next stage is indeed to find, where is the low listenership happening, and can we identify, and using, other kinds of data we have as to who's listening to, who's taking in what kinds of messages, so that we can target target messages better to the right kind of population. Overlaying on just a slight different point I wanted to make here is that, as Mr. Roy pointed out, right, research organizations often build research solutions. And in this case, we are very fortunate that we're working with ARMMAN, where it has the infrastructure to start to scale up. And we have Google engineers and so forth who are translating solutions from research labs into actual field trials. But in general, this is the hard thing, trying to go from research solutions that are built in labs to these large scale deployments. This last mile is often kind of the difficult thing to accomplish in a research setting. So, so this is a very, this is kind of the thing that's often an issue with AI for social good, is how do you go from research to actual deployment? But we're fortunate in this case that all of the different things lined up so that we were able to deliver a solution to ARMMAN. But I'll hand this over to Dr. Aparna.
Yeah, so it's a very important question, right? So there are a lot of structural barriers, and I completely agree. There are gender biases. There is the fact that there's no connectivity, right? And they keep changing their SIM cards, etc. But given that situation, it's extremely important to understand who are the low listeners. Understand one thing about India: the population is huge. It's impossible for traditional models to reach across to all women. I have seen that myself in Sion Hospital. I did my residency in Sion Hospital, where I sat in antenatal clinics where there were 200 patients waiting outside, 300 waiting outside, no time to counsel them. And I have sat in a clinic where, where I've seen a woman and written in the 3rd month of pregnancy details about what she needs to do, and she never returned, only to come back dying in labor, and I was the resident on call, and I saw my handwriting there, and I was racked with guilt. Have I counseled her enough, right? Did I tell her, give her right advice about what are the danger signs, what are the complications, etc., right? So there's an important need to kind of bridge the gap. Now, AI technology not going to cover all women, right? So we're using mobile health, right? We're going to go on to smartphones, we're going to go on to WhatsApp content, multimedia content, etc. But it's not going to cover all women. But if we can cover 60% of women, because please, women access their phones, right? I mean, and with Mitra or Kilkari, we can reach across to women more often than they can do through traditional models. So if we can reach the women who are listening to us and inform them well, and through AI models, understand who are not going to listen to us, we can prioritize them through traditional models, right?
Right,
so if
right.
3 lakh women in Mumbai, say 100,000 are going to listen to us. So I can ensure that the NGO working in that slum area sends its health worker to meet that particular woman. So we are creating a pyramidal structure, and they're helping us do that, right? Picking up the women with high risk factors, understanding what more we can do for them. So that, it is an enabler, and if we can use it well, we can actually understand which kind of solution works for which woman.
Sure. We have 9 more minutes to take questions, and just a request to the panelists, if you could keep your response like crisp and sharp, because there are so many interesting questions, and it would be a shame that we can't take all of them. The next question is coming from a physician, and this is perhaps Rahul and Ben can answer this. Being a doctor who's in his early public health career, I think there are many young doctors like me who are at crossroads on where they can gain knowledge regarding AI and their application in public health. Considering that healthcare professionals lack the programming expertise and knowledge regarding AI, is there any skilled person, and how can we ensure that we can train healthcare professionals in programming? Perhaps Rahul, do you want to answer? Is there a way to do that?
Yeah, here's what I would recommend. I wouldn't necessarily recommend learning programming, right? That's not a necessity. Of course, you're welcome to do that. But I think more important is to be a good user of technology, right? So if I want to drive a car well, I don't have to know exactly how a car works. In the same manner, medical training involves some essential training in biostatistics and so on, right? That's a good starting point, actually, because at least you learn about ROC curves and sensitivity, specificity, and hypothesis testing, and so on. That provides a basis. There's a lot of open source material out there, a lot of them coming out of medical schools on AI in healthcare. And I would recommend looking at those online courses, because they speak the language not of the computer scientists, but start with the language of the doctor, right? And bridge somewhat to the language of computer scientists. And I think my own recommendation to anyone sort of who is a young medical professional right now is AI can be, I mean, as we've heard, AI can be a very powerful tool in augmenting healthcare. So a doctor who knows how to use AI versus a doctor who does not know how to use AI, the doctor who knows how to use AI will do much better in their career.
Right. Ben, a quick response, 15-second response. Would you recommend something to Google to sort of come up with a solution for healthcare professionals?
Well, I think Rahul is absolutely right. You don't need to be a programmer to understand how to employ AI technology as well. I think I'd like to add two things. So Google does offer some courses online. The machine learning crash course, you can just Google it and then you find it. And another one is the foundations of programming. It's online courses that are available for anyone. Machine learning crash course teaches you how the systems work. You may need some programming from it, but you don't need to have that to get through it. And the foundations of programming give you those foundations to do those courses.
And I provide a few links in the chat window of some courses.
Perfect.
And I will
that
be
sounds
my alma mater, so you'll see a lot of Stanford courses there.
Great, great. Thank you so much. This question is for Ms. Anna Roy. Perhaps it might be the last question because we just have 5 minutes. But this is a question, ma'am, is for you. As there is no regulation in India at this point of time for AI, what is the initial allowed process for developers in public health to pilot their AI solutions in the field? Should they register under health technology assessment under the NHM Health Innovation Portal, or is there any other prerequisites required? A bit of a technical question, but if somebody has an AI application, how do they go about registering it?
I don't think, I'm sorry, but I don't know the process so well. So I would much rather take a rain check and get back with the exact details. But that's, I think, a very good, what we had proposed in our AI paper. Rahul was there with us, to have a portal where, you can kind of offer these solutions and it becomes a marketplace where if, say, Dr. Hegde has a problem. So she kind of posts the problem and then people can say that, okay, this is the solution. Like we are doing that for AR/VR. In AR/VR, we through NASSCOM, we did an open challenge that this is the use case where we want a solution, and some 7-8 startups kind of submitted. I think the important thing is when you talk about regulation is the data part of it. I'm aware of instances where, state governments have given access to PHC imaging data and other patient data to developers. So I think privacy is something where we need to kind of come out, and we already have a data bill, but there the guidelines, I will again try to say regulation, let us not have a heavy hand with the regulation. We need to have guidelines, we need to educate people, we need to create awareness. And I think data part of it, where you collect data, where you process data, especially in health, how do you handle the data? That is the important thing, because the tools cannot be just developed out of thin air. For each AI tool, I'm sure they are collecting data from somewhere. I think that is the part there which needs regulation. And that is where MITI is coming out with various guidelines and various frameworks.
Right. So, but at this point of time, we don't know yet which ministry should somebody approach if they have like a combination of health and AI project.
No, an NHA, National Health Authority, will be the right agency which is working on it. It is also developing the health stack. It has been made responsible for the National Digital Health Mission. So NHA will be the point where which will be dealing with the issues, and we are closely working with NHA, and we'll try to expedite some of these things about scaling up. As of now, I don't think there is any registration anywhere, but of course, since I'm not 100% sure, I would like to kind of have a caveat there. And we can always get back to you on that. But I think this is a great suggestion going forward. I'll certainly take it up with NHA, at least in health, we can start doing.
Right. Because since you're here, I want to ask you one more question, which came from our Q&A box. This is about Arogya Setu, which is like the closest AI solution which the government seems to have developed. How has been the success? Are you seeing that that people have used the app in terms of report symptoms? Have we found cases through Arogya Setu? What's been the experience so far?
the front end of Arogya Setu is not something which is the real meat. The meat is on the back end where the data gets collected. Again, I will be accused of privacy, but we are in a pandemic, and Arogya Setu is a voluntary, you are not forced to download it. But if you want to say go in a public place, if you want to fly, if you want to go anywhere else where there could be a crowd, then you need to have Arogya Setu. I think in the pandemic situation, we can deal with this privacy issues. I don't think we should be totally overwhelmed with it. But in the back end, contact tracing has been done. Hotspots identification has been done. I have the data with me, but I don't think, giving some data here. If you want, I can share all the data we have
Sure.
that collected. So on the back end, it has really helped.
Right, great. I think it's sharp 7:30, and this has been really, really engaging session. Thank you so much for all the panelists for joining us and making this evening and morning, wherever you are, a super engaging and super exciting time. So thank you so much. You can find the entire program at the Harvard website also. Have a good day and good evening.